Good afternoon, everyone. Thank you, Dr. Dubey, Sun Pharma, and the organizers for inviting me to talk on the optimal therapy for patients who have achieved T0 after neoadjuvant chemotherapy. Greeting from both the hospitals where I'm working, as Dr. Dubey has mentioned, we have been working here for the last 20 years here, 28 years, where we started urological oncology department. Now, NACT has become a standard of care for T2 to T4, N0, N2, and M0 disease, and most of the guidelines have recommended as a strong recommendation, EAU, AUA, NCCN, which I had an opportunity to have looking through all those guidelines, and International Bladder Cancer Consensus Group, and this is how actually I did a lot of work on patients who actually needed further treatment for PT0 or CT0 after neoadjuvant chemotherapy. And recently we had a meeting in Houston, the International Bladder Cancer Group Consensus meeting, and here also this issue was discussed along with intermediate high-risk bladder cancer. So what happens after NACT? You have a downstaging, what we call as DS. You can achieve T0, or you can have TA, T1, CIS, or T4 can become T2, or on the other side, you will have a very poor response and patients would have disease progression. To show you a simple case, which we just recently did, was a 49-year-old gentleman who had a high-grade muscle invasive disease, clinically T3 disease, N0, M0, had a lesion on the left lateral wall. And we usually use dose-dense MVAC rather than gemcitabine cisplatin. And here you can see the response here. You will see patients who have a lesion in the left lateral wall of the bladder. This is before treatment here. And subsequently, you see what happens after treatment. Almost the whole disease is gone. And this is seen in the PET scan. This is before treatment and after treatment. And there was no metastatic disease anywhere in the abdomen, and you can see an excellent response with DD-MVAC. So we achieved T0 in this guy. He's a young guy. So what do we do next? I think the typical scenario in an MDT meeting or your outpatient practices is the first question comes to is, do I need to undergo radical cystectomy? This guy has agreed to undergo cystectomy. That's why he had NACT, but he would come and ask, do I really need to have cystectomy now? Enthusiastic family members who get excited about this response would certainly ask, can I preserve my bladder? Can I use that? And can we use RT, CT to consolidate the treatment? With such a good response, can you give me more chemo consolidations? Or people would say, I have good response now. Can I just have observation and do a check cystoscopy? And this is typical a discussion what we get in a clinical practice. What he underwent was a radical cystectomy, bilateral pelvic lymph node dissection, and neobladder reconstruction. And this is how it looks like. You have a beautiful specimen there. You see this ulcerated area there within the center. And the pathology showed PT0, N0. There is no residual disease. But I'm glad, as Dr. Dubey has also mentioned, now NACT has become accepted, not only accepted, but is practiced as a standard of care. And I'm very glad about it. So why do we choose cystectomy? I think our initial intention was to have a cure. NACT was for downstaging the disease, to clear the micrometastasis, and not to replace the surgery. Let it be clear about it. Radical cystectomy would clear the disease completely, and downstaging, what we call as DS, to T0 has shown have excellent long-term disease-free survival. That's a rationale why we need to do a cystectomy. And I will support my statement by the literature here. This was a paper which came in April 2016 and looked at the final histopathology. If you have PT0, they have a better survival than even patients who had downstage to TA and TIS, and this was supported in Journal of Urology. And they looked at more than 1,500 patients and looked at the patients who had 257 patients who were PT0 and about 207 patients who had TIS and TA. And you see the difference in the survival. 186 months for patients who had T0 against 138 months when patients had T and TIS. So obviously, this is a surrogate marker. If you achieve PT0, the patients are going to do very well. Another study which came from the Norway, which is a population-based study, it also echoed the same thing. You look at the arms on both sides, you will have no a neoadjuvant chemotherapy versus neoadjuvant chemotherapy. And here you look at the difference here. You look at the base here, the bottom here, where patients who have achieved PT0, they did extremely well as compared to the patients who did not achieve PT0. So this DS or downstaging translates into a better survival, 80% versus 38%. So what I'm trying to say that you do NACT, have sort of a good response, augment it with radical cystectomy, these patients have very good outcome, which is also reflected in the graph on the left-hand side. You will see the downstaging, you achieve T0, these patients do very well. Now let us look at the other options following 2-0 in ACT. Science is always progressing. Temptation is to save the bladder. So the patient and his family always would push for it. I mean, we really don't want to have a surgery. Reluctant surgeon. Surgeons, as you sort of grow, like I'm growing now, over the period of time, you understand the patients have large morbidity, 30% morbidity, high mortality, 30% readmission rate. So you keep on questioning yourself, am I going to do cystectomy in each and every guy? Or also many times you sit in MDT, the over-enthusiastic, over-optimistic and aggressive medical oncologists would say, hey, we are having good response, so why not sort of consolidate with it? So what about this RT or combination of radiotherapy and chemotherapy in this patient? So let us actually look at the evidence. This is a good paper which came a few years ago. You do cystectomy versus bladder preservation after NACT, and the answer lies here. What has been done is these patients who have neoadjuvant chemotherapy, 4 cycles, and then subsequently evaluated with cystoscopy and CT imaging. If there is a complete response, which you see on the left-hand side, then these patients would be offered either cystectomy or patients would have a bladder preservation. That's one arm. You look on the opposite side, the patients who do not have good response, they do not continue with sort of further treatment, but subsequently these patients would have a cystectomy or otherwise they're unfit, you offer some different treatment. Now this table will tell you in these patients who have NACT, what happens to them if they undergo cystectomy and what happens to them if they undergo radiation or consolidated chemoradiation. And you will see at the bottom here, if you have radical cystectomy after neoadjuvant chemotherapy, the mean overall survival rate was about 61% as compared to patients who have undergone consolidative radiation and chemotherapy after NACT. And the mean overall survival rate was something in the range of 53. So this is quite comparable, as you would say. And this is to give you more data. So radical cystectomy as well as radical radiotherapy have almost sort of a good response. But I think the question, again, debatable would be what's the quality of life as such. And the conclusion in that paper was, yes, radical cystectomy is an option, but a combination consolidated radiation chemotherapy after NACT is neither inferior either. So it's not inferior at all. So you can actually sort of use this modality as an alternative to cystectomy. Now, this is a paper which just last week, and being part of BJUI editorial board, you always get a chance to these get sort of firsthand. When you review this, you write comments on those things. And this was a wonderful paper. So this actually has a systematic review and meta-analysis of trimodal therapy versus radical cystectomy. Mind you, this is a systematic review, not something only pertaining to NACT followed by RC or sort of a CT-RT. But it does suggest that it has equal sort of a response. I mean, you would have radical cystectomy on one side and trimodality on opposite side. I think they do extremely well. The problem here is, if you read in between the lines, is the disease relapse. The bladder cancer relapse rate after trimodality therapy ranges between 30% to 40%. And I'm sure we all urological oncologists, we know that you advise them trimodality therapy. In my practice, 1 in 4 patients would require a salvage cystectomy. I'm sure all the senior guys, Dr. Jagdish Kulkarni and the senior guys would also mention, Dr. Gupta would also agree that patients who have trimodality therapy, they would land into having a salvage cystectomy 1 in 4. If the patients have sort of recurrence-free survival in radical cystectomy group is much better, but usually 1 in 4 patients would need a cystectomy. And this is again supported by another sort of large meta-analysis by FEMI, which suggested that both arms are having equal outcome. So why we choose radical cystectomy as against to radical radiotherapy? If the literature says it is good as radical cystectomy, to answer this question, I would say we will know the final T stage only by doing a cystectomy. Because if it has a residual disease, it may warrant some sort of additional therapy, maybe immunotherapy. It will tell you the prognosis. The residual disease may warrant adjuvant therapy. And as I mentioned to you, 1 in 3 or 1 in 4 patients in my practice require salvage cystectomy. And also, patients who have undergone trimodality therapy, they would require check cystoscopies lifelong. They require imaging forget about the debate of MRI or CT to be done in bladder cancer, these patients would have a high risk of disease recurrence. People talk about quality of life, I'm preserving my bladder, but at what cost? Frequency of micturition, hematuria, repeated UTIs, upper tract changes, proctitis. I think this is not as equal as what good quality of life we would have wanted when the patients would have either new bladder or ileal conduit. This is typical an example patient who had a trimodality therapy after NACT. And patient has a fistula in the suprapubic region. And to do a salvage cystectomy in these patients, the life is not easy. You get sort of a lot of edema. The bowel is not so good. You have a lot of complications. So the downside of using radical radiotherapy and chemotherapy after NACT has this kind of downside. Dr. Sonpavda is here, and I think he was one of the authors in this paper which was mentioned. What is the optimal pathological response after NACT? And I think we will have his comments as well at the end of my talk. He's actually sort of the paper is so good, it does mention that if you have sort of a response of something like T0, these patients would do very well. But anything beyond that, I think these patients would certainly require some additional therapy, maybe an immunotherapy, and the time would tell us. So in nutshell, I think NACT definitely works. Most of these patients would do very well if they've achieved sort of a T0, final PT0 after NACT and a radical cystectomy. And in his paper, I think this is all clear. You get a final after NACT through cystectomy, again it's T0. These patients are going to have an excellent sort of a 5 and 10-year survival as compared to patients who had TA and TIS. Now, this also clarifies the issue that doing nothing or consolidative chemo, as some people would ask for, is not an option either, because these patients need some additional treatment after T0, however tempting it could be, because people are very happy, I got excellent response, imaging is good, cytology is negative, scope is normal, but I think they require an additional treatment. And this is reflected in one of the sort of a review article which came in Journal of Urology, where it has taken through all of us, to the management trends in sort of a radical cystectomy. Here you would see patients are undergoing sort of neoadjuvant chemotherapy, and also the bottom line is it has been practiced all over. The change in sort of last 10 years has been so good, and we are seeing excellent response, and that should be the case. So in conclusion, post-NACT T0, radical cystectomy with PLA-ND is a better option. RT or RT plus chemotherapy is an option with sort of an inherent risk of salvage cystectomy, prolonged follow-up, and risk of disease progression. Survival rates are comparable. Quality of life can be a debatable issue. Now what's coming up? Last few slides. What lies in future? Now we are looking at something like neoadjuvant immunotherapy. We have seen excellent response. So why not use immunotherapy? Yes, cost can be an issue as a neoadjuvant setting. So we are seeing good response in metastatic disease. But like in RCC, what we were discussing just before, you will have an issue of the cost. Toxicity profile is not sort of so benign treatment. There could be people who are good responders and non-responders. We don't know for sure. People are using chemo and immune as a combination, and can we predict and choose which one? I think this is the challenge what we have in future. And this is an excellent review here. What we can do is use molecular testing to guide the preoperative systemic therapy for urothelial cancer. And I'm sure you all know about the role of ctDNAs, circulating sort of tumor DNAs. And this has come in a long way now. So maybe the future, we'll be looking at sort of circulating sort of DNAs, and this is how it is done. You can use from a urine sample, you can use from the blood sample, and ctDNAs would certainly be a thing to look for in future. Today's EUA guidelines now suggest that yes, immunotherapy with checkpoint inhibitors as a monotherapy, or probably in a different combinations or without chemotherapy in phase 2, 3 trials have shown good response, good sort of promising result. And maybe if you want to use genetic markers to predict which one to use in these patients, there is a strong recommendation for this. So if at all you want to use neoadjuvant immunotherapy, it would be something in a trial setting, but still there is a strong recommendation if you want to use in a trial setting. So what the scenario would look now? In 2025, yes, we should all use NACT. Maybe we'll be using ctDNAs, biomarkers, molecular subtypes. Maybe use dd-MVAC as against to GC. I think there is enough literature to suggest that dd-MVAC works much better than GC. However, There is sort of controversial sort of statement saying that GC is equally good as DDM-VAC and neoadjuvant immunotherapy. So once they get that, then perhaps you will see whether they would require cystectomy or radical radiotherapy. Lastly, there is one phase 3 trial done in UK which will tell us answer now. So patients get NACT, they will be randomized, they are being randomized into radiation therapy versus surgery, and I think the results would be out very soon. So I think, friends, I hope I made it very clear. NACT has come in a long way. Radical cystectomy is the preferred option, but in select group of patients who really want to sort of carry on and preserve the bladder, you can use chemo and RT in these patients with a rider that they need a long-term follow-up with chance that they would need a salvage cystectomy. Thank you very much again, and thank you, Dr. Dubey and Sun Pharma.
Thank you very much, Makarand. Continuing on that topic, there was another paper wherein they followed about 65 patients who became T0 after NACT and refused a cystectomy. And these patients were followed up without receiving any other treatment. And at 5 years, apparently 87% were alive, good overall survival. Most of them had recurrences which were low grade, not muscle invasive. And that kind of at least raises a question that some of these patients may do really well without any additional treatment. Secondly, and I have a patient who I'm following up for the last 10 years. He had muscle invasive bladder cancer on TURBT, complete R0 complete resection. NACT was doing good for 6 years on regular. He was so paranoid about losing his bladder that he said nothing. Then he came back with a recurrence in his trigone and prostate, which on biopsy was again high grade T2. Again, he refused a cystectomy. This is 3 years back. I said, we have exhausted the treatment options. And then our oncologist gave him again 3 cycles of NACT for the second recurrence, along with pembrolizumab, which he took for 1 year. And he is disease-free for the last 3 years. So the question that comes to my mind is, 8 years this guy has gone through without losing his bladder and maintained an excellent quality of life. So my question is, does this kind of intense treatment, which is probably going to happen in the future, and Dr. Guru can tell us whether the combination of chemo plus immune checkpoint inhibitors will be able to see a select group of patients avoid any treatment after the neoadjuvant treatment?
I hope so, because we were very critical about using chemotherapy before even cystectomy. I'm sure all the senior guys here, and I also went through that phase. We were saying no to chemotherapy. We want to go cystectomy, and if at all patient had adverse characteristic, augment them with chemotherapy. But now I think we have to accept the fact it works. Also, immunotherapy works much better than chemotherapy. So I think we have to accept that. So answering the 2 questions what you asked for, the first patient what you mentioned about, I think he's doing so well because the answer lies into what was his first stages like, what was his histological subtype like, maybe luminal, non-luminal, and genetic makeup, number 1. And the second patient, I think he's justified, but all the literature today suggests that there's a striking difference. Patients who have achieved T0, and you would say, what about patients who have TIS and TA? I mean, they should do almost same way, but they don't do very well. So the literature is in abundance. Maybe a single case where patient has done well, but as I rightly said and also mentioned in my talk, in ctDNAs is coming in a big ways. Which one to use is also coming in a big ways. So I think we have an exciting future. And mind you, I think there will be a time when we won't be doing cystectomies, maybe in a few years' time.
There's a couple of points I want to make. One is that I think we're not ready to completely omit local radical therapy. Like, after neoadjuvant chemo, there are some studies out there suggesting that you can avoid both cystectomy and radiation and just watch patients with clinical T0 disease. But I want to point out that the clinical staging is really suboptimal when you can add ctDNA, urine tumor DNA, things like that, but we don't have great clinical staging. So really, avoiding all local therapy is a problem. You may have seen a recent study, the Sunrise 2 study, which compared chemoradiation versus just systemic therapy with sertralimab, PD-1 inhibitor, plus intravesical, the gemcitabine slow-release TAR agent that was stopped early. So I think we're not at the point of avoiding all definitive local therapy. So I think either cystectomy or radiation should be done at this point. I know you pointed out a study where just systemic chemo alone was potentially curative in around 30% of patients. Again, that's not optimal, right? You want to see more than that. So again, that could be an option, but we don't have a great biomarker for patients. ERCC2 might be one biomarker, which seems to predict really high PAT-CR rates. That's been validated actually. Only problem is we cannot use it to deny neoadjuvant chemo because it's only present in 10% of patients. So at the moment we're stuck with, we don't know who are those patients where we can avoid cystectomy. And also the chemo versus chemo IO has been positive. You may have seen the Niagara trial at ESMO recently. We expect that to be approved, chemo plus durvalumab in the neoadjuvant, 3 months followed by 8 more cycles of durvalumab, improved EFS, hazard ratio 0.68, improved OS 0.75. So we expect that to be out there. So there are some, again, we don't know, I wish we had a biomarker to predict who are those patients who benefit from durvalumab, because the absolute improvement is only about 10%, long-term improvement in OS. We need a biomarker for that.
Yeah, I think the biomarker,
Sir,
biomarker would be the key thing as such. And I think I'll just add one sentence here. Like Dr. Dubey mentioned about these patients who had sort of chemo and did very well. Patients who are octogenarians, who refuse cystectomies, even if you look at the SEER data, patients who had a radical TURBT alone, nothing has been done. I think there are a lot of patients who have been doing extremely well for some time. Yes, last question.
Sir, last question. I just wanted to bring to the notice that in 2023, the SEER database, which evaluated about 16,000 patients with MIBC, they compared NACT and adjuvant chemotherapy. And they say probably the maximum benefit in the patients of NACT is in the E2 group. That E3 and E4 group, whether it is NACT or adjuvant chemotherapy, both are equivalent.
Yeah.
So what's your take on that?
Yeah, I think I agree. I think the lower the stage, like T2 is the most ideal. If you have node positive disease T3, T4, they do not do as well.
I just want to make an argument and comment regarding what Dr. Deepak Dubey has said. That if you have seen that histopathological specimen outcome of PT0 in a MSKCC data, and they have 30% patient who has PT0 actually has some disease, residual disease in the final specimen. And those patient actually probably is going to have a recurrence and a bad recurrence. At the same time, you are saying that 1 in 4 patient who is getting RT plus CT and getting a salvage cystectomy over the time, so 30%. So ultimately 30% here and 30% there. So why not keeping an observation? So I think this is a valid option if the patient is motivated, as said. So it's going to, over the time we'll see this change over this.
That's the reason to have that kind of debate as such. There is no right answer, but I think next 5 years we'll have the right answer.
I think for those patients who are very reluctant or refuse a cystectomy, there are good options to follow up and see what happens.
Yeah, thank you.
Thank you very much, Makarand.